Hello and welcome back to this Doc Talk program focusing on the clinical utility of angiogenesis inhibitors in metastatic colorectal cancer. In the first session, we gave you a lot of background about what the standard of care was up to 2012, and then talked about targeting VEGF and targeting VEGF-R with new agents and new uses of previous agents. So in this session, we're going to discuss some clinical scenarios and give you an idea as to how our expert panel manages their own patients, both in a clinical trial setting and in a non-clinical trial setting. So let's begin with the first case. And this is a 61-year-old retired investment banker, which initially makes me think I went into the wrong field if this guy is already retired at 61. But he has excellent performance status. He has no significant comorbidities. He drives to his country club every day without any problem. But he has a recent history of rectal bleeding and abdominal pain. Colonoscopy reveals a friable mass in the cecum, and biopsy is positive for adenocarcinoma. So CT of the abdomen and pelvis shows 5 intrahepatic metastases, maximum of 5 centimeters. 2 of them appear to be close to hepatic veins, and there are also peritoneal implants. CEA level is 20 nanograms per ml, and KRAS mutation testing shows that this patient's tumor is KRAS wild type. So what do we need to consider in this situation is extensive hepatic metastatic disease close to the peritoneal veins. He's not a good candidate for resection of those lesions, and in addition, he has peritoneal metastases, which puts him out of the curable range, and this becomes a palliative setting. So let's turn to Axel. So what are your thoughts when you see this 61-year-old previously healthy man who now has got a real problem with KRAS wild type stage 4 adenocarcinoma of the cecum?
I think the most important problem would be to communicate to him that he can't be cured. And I think this is one of the points we need to make very early on in a setting where we can really not hope for, let's say, eradicating all visible metastatic disease using an interdisciplinary approach. So this is clearly a palliative setting, as you outlined. Goal of therapy is to extend the duration of the patient's life and maintain his quality of life. He probably wants to golf or whatever, for a long time. And I think we can do this nowadays for many years, and the question is more, how do we approach this in a sense that we can control his disease as long as possible, interfering with his quality of life as little as possible with our treatment options. So I think in a KRAS wild-type colorectal cancer setting, palliative setting, unresectable disease, we tend to use a combination chemotherapy regimen, especially in a patient who is younger, otherwise healthy, plus an biologic agent, bevacizumab, or here in this case, KRAS wild-type EGF receptor antibody is potentially doable. In an older patient, we could even use fluoropyrimidine plus bevacizumab based on the data that we've seen presented at ASCO GI capecitabine bevacizumab. But in this patient here, we'll probably shoot for combination chemotherapy, and I would rather use a VEGF inhibitor up front than an EGF receptor antibody. And the reason why I say that is the perceived strength of EGF receptor antibodies over, let's say, bevacizumab in first-line therapy might be more response that you see in terms of measurable response, which is not what we need here. We're trying to shoot for time and quality of life. And a patient like him who has a social life, etc., probably doesn't want to be stigmatized by potential rash, for instance, or subjected to, hair loss, for instance, that would kind of characterize him as a cancer patient. So I would, in my practice, I would use a regimen like FOLFOX bevacizumab as first-line therapy, being mindful about the cumulative neurotoxicity that can occur and will occur at some point if we don't pay attention and opt for, let's say, induction maintenance therapy approach, utilizing only a certain number of cycles of oxaliplatin-based therapy, and then switching to what I consider one of the standards of care, practice standards of care in maintenance therapy with a fluoropyrimidine plus bevacizumab, and keep the patient on this treatment as long as possible. We could then potentially reintroduce oxaliplatin at the time of progression, switch to a different treatment regimen depending on the velocity of the tumor progression that we might see, which we can discuss later. But I do believe that as a first approach, after discussing with this patient, that goal is really to shoot for time, duration of life, limiting side effects, not stigmatizing him necessarily up front. This can come later, and we have data using EGF receptor antibody as salvage therapy. I use an induction maintenance therapy approach, FOLFOX bevacizumab, followed by fluoropyrimidine bevacizumab as maintenance therapy.
Very good. Jolene, let me ask you, what do you do at the Mayo Clinic, about the primary tumor? This guy has a friable bleeding mass in his cecum, and you're going to start with FOLFOX bevacizumab. Are you concerned about the primary? Do you keep in the back of your mind that I might have to deal with that primary tumor at some time in the future?
Yeah, that's a very good question in a much debated area, what to do with the primary tumor in the setting of a metastatic disease which is incurable. And unless there is a surgical emergency, I tend not to send these patients to surgery and just go ahead and treat them right away with an oxaliplatin-based regimen with bevacizumab. And oftentimes we'll see a decrease in the bleeding. It'll stop. Hemoglobin will normalize or stabilize. And oftentimes you can treat these patients for extended duration, and most of them never have a complication from their primary tumor.
Actually, we should highlight, Jolene and I are going to have a debate on this tomorrow, a stage debate at our Great Debates meeting, which we should, of course, advertise for, which is a very I think, comprehensive approach towards GI malignancies. And Jolene is taking we should not resect the primary tumor, and I unfortunately have and I don't spill the beans here, I have to vote for resecting the primary, which I do not use in my clinical practice. So I completely agree with what Jolene said.
Very good. Well, Scott, let me ask you, you're at the famous MD Anderson Cancer Center where all patients are cured of their malignancies. And this guy comes in, he's a high power investment banker, and you tell him that his situation is palliative. And there's so much on the news and the press and the media about all these phenomenal breakthroughs in cancer therapy. When you're challenged by someone, how can that be? What do you mean I'm not curable? I feel pretty good. How bad can this cancer be? What kind of approach do you take that our community docs at home can take to bring this person around to the fact that, this right now with today's technology, this is really not a curative situation?
I think the first approach is really to acknowledge the limitations of the tools that we have, and that while we are making progress in the field, we're really with chemotherapy, we're not curing more patients. That we can extend life for periods of time, stop the tumor from growing, improve quality of life for patients during that time. But really, we don't have the tools. We don't understand enough about cancer to really get to the point that we'd all like to be, which is being able to cure the patient. And sometimes that message gets lost in the enthusiasm for the latest breakthrough. But these are incremental advances, additional tools in the toolbox, but really aren't able to do what we'd like.
And I think the critical issue is, we have some patients, we all share these patients, who shop around until they get the opinion they'd like to hear that there is a surgical option in a situation where everyone who's reasonable would say there is no surgical option. And this, I think, is a danger. And, we've referred patients back and forth between MD Anderson and Mayo Clinic. I think the consistency of our message, I think, is very important for these patients.
So let me ask one other question. When you say, Axel, that you would start with FOLFOX bevacizumab, is there any evidence that bevacizumab works better with FOLFOX than it does with FOLFIRI, or do the anti-EGFR antibodies work better with an irinotecan-based regimen or an oxaliplatin-based regimen, or is everything pretty much equal?
And that's an excellent question. It's a question actually that's highly debatable. And debated. I think the main interaction, the positive interaction for bevacizumab comes from the fluoropyrimidine component. We see a lot of data now emerging that if you really look closely, even the initial IFL plus bevacizumab trial, there was a component of patients that just used 5-glucovorin plus bevacizumab, and those patients actually did very well. The question is really, and the critical question in the context of fluoropyrimidine bevacizumab, do you really need irinotecan or oxaliplatin? Now, I do believe if you shoot for a long-term duration of therapy, if you deal with the neurotoxicity issues of oxaliplatin, allow the patients be on continued VEGF inhibition longer term, I think the outcomes between FOLFOX and FOLFIRI are very similar with data from the observational study BRIGHT, where patients either had FOLFIRI or FOLFOX. The survival curves, PFS curves are perfectly overlapping. Now, for EGF-receptor antibodies, I think the data are not as consistent, and there's the perception that it might just be working better with irinotecan. We have more data with irinotecan. Then there's some data from oxaliplatin-based regimens with a different fluoropyrimidine backbone that were not as convincing for EGF-receptor antibodies. But I think bottom line is that at the time point when we normally utilize these agents, at a time when patients have gone through several lines of therapy and then get, for instance, treated with irinotecan-based regimen plus cetuximab or panitumumab, I think it really doesn't matter that much anymore.
Very good. Well, let's move on to the second situation. So this 61-year-old man receives 8 cycles of modified FOLFOX7 without the bolus 5-FU, and he gets a really good response in his liver and his peritoneal metastases. Is stable disease. He's on capecitabine and bevacizumab alone without the oxali for about 6 months, but then imaging studies show some progressive disease. He has no significant residual neuropathy. And his hand-foot symptoms are really very mild. A little bit of hypertension, but that's been controlled. So now, however, he's got progressive disease. What are you going to do at this point? Are you going to add the oxaliplatin back in? Are you going to switch to FOLFIRI? Will you continue Bev? Will you switch from Bev to aflibercept? Or will you switch to just irinotecan and cetuximab? I mean, this is KRAS wild type, so getting a really good response, but now he's got progressive disease. So what would your approach be, Axel?
So, a lot of the options that you mentioned, are valid options. I mean, nothing is kind of out of the ordinary. I look at the data more or less for, in this setting, continued VEGF inhibition because the patient had already benefited from VEGF inhibition. We had pretty long time to first-line progression, even with the kind of low-dose capecitabine bevacizumab maintenance therapy or chemo light phase. I think he had significant benefit in terms of the duration of therapy until patients showed progression. The question is, if we add oxaliplatin back, for instance, we could even consider this patient still on first-line therapy because he had really not failed the combined approach of, let's say, using oxaliplatin in conjunction with 5-FU and bevacizumab. So one of the valid options of a patient who had not experienced any neurotoxicity is to reintroduce oxaliplatin, form another FOLFOX plus bevacizumab regimen. I wouldn't even consider this in second line, let's say TML-like therapy. We're still on first-line therapy. This is Optimox. This is something that has been shown in the so-called concept trial, which was conducted several years ago. So we can add oxaliplatin back in and continue bevacizumab. Now, the other option, if the patient had neurotoxicity, we could switch to an irinotecan-based regimen. Standard would probably be FOLFIRI, based on the TML data, plus bevacizumab, because this patient did not have rapidly progressive disease. He would have met the eligibility criteria for the TML study, which showed that using bevacizumab beyond progression actually showed survival benefit.
Very good. Well, Scott, this guy has been on 3 agents. He's been on Bev, he's been on a fluoropyrimidine, and he's been on oxaliplatin. He's off oxaliplatin for a while. He's still been on Bev and capecitabine. How do you know whether or not his disease is still sensitive to a fluoropyrimidine? I mean, should you continue the fluoropyrimidine, or should you say, well, that's a lost cause, I'm going to switch just to irinotecan and cetuximab?
And I think that's a good question. And this is where we have data looking across trials, perhaps, but we don't have good randomized data to answer that. I think what we can say is that FOLFIRI is a well-tolerated regimen, and that the addition of 5-FU does, on the biologic sense, appear to still be continuing to provide some degree of synergy with these. I think the key point with this is recognizing that in the setting of toxicity, trying to make a decision about what to modulate within FOLFIRI is important. And this is a setting where we have a low threshold for the reasons that you stated for starting to drop the bolus of the 5-FU very early on if there's fatigue or myelosuppression, or dropping the infusion doses of the 5-FU. So I don't think we have a clear answer to that, but I think some of that thinking does go into the decision making on how to adjust treatment as we move forward.
Very good. Jolene, any comments?
I agree with both of our experts here, and I think usually after eight cycles of a FOLFOX chemotherapy, people have some degree of neurotoxicity, and so usually, though in this case the patient was fortunate enough not to have it, usually they do have some. So I will oftentimes switch to irinotecan just to give their body more time to recover from that neurotoxicity, and then save oxaliplatin for a time in the future. For instance, if their disease becomes resistant to irinotecan, then use the oxaliplatin again, and hopefully that duration of time has allowed the patient to recover from the neurotoxicity.
The longer oxali-free interval, the more likely it is to be beneficial. Very good.
I think one of the important points to remember in clinical practice is really making a notation of why the oxaliplatin was stopped. I think one of the things we see in referrals is patients coming in as oxaliplatin refractory when perhaps there's a situation like Jolene mentioned where this was stopped early. And so there's really an opportunity to re-challenge these patients to oxaliplatin. And I think in our standard of care practice, we need to make sure we don't miss that opportunity.
Okay, so let's look at the third scenario. This is the same patient, except he has been on mFOLFOX7 for just 4 cycles, 2 months, and he's had a minor response, but 2 months later, he is reevaluated and he has rapidly progressing disease. He's got problems now, not only in the liver and the peritoneum, but also additional metastatic disease. So this is rapid progression on primary first-line therapy. What are we going to do? Scott, let's just go to you with this one. This guy's got a real problem. Do you accept that oxaliplatin has failed? Do you switch to a different regimen, continuing bevacizumab? Do you switch completely to just irinotecan and cetuximab, or do you consider a clinical trial?
Right. So this is a situation that we come across, not very commonly, but it is something that really challenges our understanding of the flow of patients through these treatment algorithms. I think one thing is when we see this, we should start to recognize that perhaps this is a different biology than we're used to. And I think there's been increasing recognition that there is a very unique subset of colorectal cancer that has a very different biology, a different clinical pattern that is defined by a mutation in BRAF. And so there are implications of this for very tailored clinical trials that should be considered. So one thing that I would encourage in the setting of disease that's not behaving like a quote-unquote garden variety colon cancer, in the setting of a wild-type KRAS, is test BRAF if not already. Now, having said that, what do we do in this patient? We need to make a decision now, and we can assume perhaps that he's BRAF wild-type. In this setting, what we will commonly do is to change the backbone, change the biologic completely. So this is a setting that we would commonly use a FOLFIRI and cetuximab regimen. with the idea that using a different cytotoxic backbone, perhaps EGFR inhibition, may make sense. There are other options, as you mentioned, with the use of development of aflibercept, perhaps that has a role here. But I think we have the most experience and evidence that using an EGFR inhibitor may provide better efficacy in this.
So switching to like FOLFIRI-cetuximab or FOLFIRI-panitumumab.
Correct.
All right. What if it turns out that he is BRAF mutant, Jolene? So is this the same BRAF mutation that we see in melanoma, the V600E mutation? And if so, is there a role for a clinical trial with a BRAF inhibitor or a MEK inhibitor? Is there any evidence that there's potential efficacy along those lines?
Yeah, so interestingly, it is the same mutation, the V600E, but is not as responsive to the BRAF inhibitor vemurafenib as melanoma is. And actually, Dr. Kopetz here actually performed that study looking for any efficacy of vemurafenib in the BRAF mutant patients. And unfortunately, we did not see the responses like they saw in melanoma. I think probably the most important thing is, as Dr. Kopetz said, to look for a clinical trial for these patients. The second thing is this is also prognostic for the patient as well. The BRAF mutant patients typically have a more aggressive tumor biology, and I think that helps in terms of planning and preparing the patient for maybe more or a shorter lifespan, and trying to help guide them through that.
All right. So Axel, I see you nodding your head. I mean, what do you, for this patient is in your practice, and he's got rapidly progressive disease on FOLFOX/Bev. You test him, and he's BRAF mutant. Are you going to offer him FOLFIRI-cetuximab or something different?
If I have a trial available that looks at, let's say, combined inhibition BRAF plus MEK plus an EGF inhibitor or PI3 kinase inhibitor, I mean, Scott himself is actually developing a trial right now that will hopefully be available for these patients on a national scale at some point in the future. And it's not trivial because we need to screen a lot of patients to tease out these 8% of patients that in the second-line setting are still candidates for a clinical trial, and they should be enrolled in the clinical trial because, as Jolene said, the prognosis of these patients is poor. So if I have a trial available, or if I have a referral center in close reach, that has a trial available, these patients should really preferentially not be treated, BRAF mutant tumors, not be treated, if possible, with, let's say, irinotecan, cetuximab, but should be funneled into clinical trials. And I think we need to create awareness where these trials are being opened. And I think this is a very precious patient population, which allows us more or less to do what breast cancer and lung cancer has already done, meaning identifying a molecular subgroup of patients with a very distinct biology and developing really designed, tailored treatment options. And I think this is our best shot we have right now because of the unique characteristics of BRAF mutant tumors.
Good. So Scott, tell us about this trial and what you're trying to do, and also tell us whether or not there's a role for continued angiogenesis inhibition in a patient like this who's obviously failed rapidly on FOLFOX/Bev.
Yeah. So the study, the experimental efforts moving forward are recognizing that this mutation is a driver in the tumor, but that it's in a context of a lot of other changes in the tumor. And so the efforts ongoing, both the study that hopefully be opening later this year, as well as other studies that are coming, are really trying to target both this driver mutation and some of these other critical mutations, these other critical factors that appear to be driving some of the resistance. In our current state of understanding, we haven't seen an interaction with the angiogenesis pathway with BRAF mutations, but this is still a very early field, and I think what we can say is that there's still a lot to learn about this, and there may indeed in the future be a role for these.
Can patients who are KRAS wild-type BRAF mutant benefit from anti-EGFR therapy?
It's So it's an excellent question. I think the point that was made earlier, these patients have very poor prognosis. And so a lot of the early studies that suggested that EGFR inhibition in the setting of a BRAF mutation doesn't work, we're actually seeing a very strong prognostic effect. I mean, they were going to do poorly with whatever treatment that came. When we look at this systematically and more robustly with clinical trials, there's a suggestion that there are indeed some modest benefits perhaps with continued with EGFR inhibition in this setting. Although the difficulties that were raised, this is a small population, and we have to be careful at really trying to tease out too much out of some of these subsets. So I think what we can summarize and say that EGFR inhibition outside of a clinical trial has very modest to no activity. We don't yet fully understand, but clearly we think that clinical trials that may be combining EGFR inhibition with something like BRAF inhibition may be a better option.
Very good. Well, let's move on to the final scenario. So this is our 61-year-old investment banker. He's had the mFOLFOX7 plus Bev for 4 months, and then he got Kate Bev for an additional 8 months. Then he went back on mFOLFOX7 and Bev for 4 months, and then he got FOLFIRI. So now he's progressing. He's had, 4 lines of therapy, some of which have been similar, but he's got progressive disease. Is this the patient who is ideal for regorafenib, or is this someone who should go to a clinical trial? Is ramucirumab an ideal clinical trial for this man, or are there other things? So Axel, why don't you take that?
I mean, if we still consider that this patient might be KRAS wild type, EGF receptor antibodies haven't been used yet, so here's another line of kind of standard therapy with, let's say, EGF receptor antibody with or without irinotecan. In contrast to, let's say, the VEGF inhibitors, EGF receptor antibodies have single agent activity, so you could kind of push one line before the inevitable regorafenib, which we use as salvage therapy setting. The question is, since regorafenib is not non-toxic, are those patients already gone through, let's say into a poor performance status from their disease? Are those the best candidates for regorafenib? Is there any kind of future trials that would move regorafenib earlier in earlier lines of therapy? That's an ongoing debate. Right now, regorafenib would be after EGF receptor antibody failure, which the patient hadn't had. Now, if he had a KRAS mutant tumor, he would not have the option of cetuximab or panitumumab-based therapy. So then regorafenib would indeed be the next line of defense, with the idea that the drug doesn't really induce a lot of responses, can control tumors. At best, it's like disease control versus really not responses as much. And we need to be mindful about toxicities that come early. I mean, the regorafenib toxicities flare up in the first 1 or 2 weeks even. So we need to actively manage these patients, and we've already talked about some issues about dose adjustments early on and prophylactic management of the skin rash, etc. So I do believe, at standard medical therapy, this patient still has options, even in the wild type or mutant KRAS situation. And I think Scott pointed out later, these patients might actually really be candidates for oxaliplatin again at some point if they had stopped oxaliplatin, not for progressive disease reasons. Sometimes we see patients who had a hypersensitivity reaction, which we can override to some degree, desensitize patients to these hypersensitivity reactions. And we see the longer we treat and the more we use oxaliplatin, the more we see these hypersensitivity reactions. Is the reason why patients are sent to us saying, we can't use oxaliplatin. We do desensitize patients. I mean, we override the allergic reaction with some potential benefit. So in the end, it all depends on how well this patient is in terms of performance status, in terms of comorbidities, etc., that we talk about, and whether we're still in the right balance between duration of therapy, being actively treating the cancer, and maintaining quality of life.
Absolutely. So Jolene, let me ask you, regorafenib's been on the market for a little while now, standard dose, 160 milligrams a day. Do you start everybody at that dose, 21 days, or do you start at a lower dose, or Do you consider maybe 2 weeks on and 2 weeks off to see how they do? What are you doing up in Rochester, Minnesota, where there's still snow on the ground, right, Axel? Yeah.
So we are actually starting at the 120 milligram dose and seeing how patients tolerate that for the first cycle. Doing toxicity check with laboratory studies a couple weeks after starting to make sure they're tolerating the medication well. Also very proactive of telling them what side effects to expect. And often these side effects will come on fairly rapidly in terms of the hand-foot syndrome and diarrhea that can occur, as well as fatigue. And I try to get them to be very proactive in terms of their hand-foot syndrome, doing the urea-based creams, and if patients will do this, actually wearing gloves at night with the creams on both their hands and their feet. If they have any calluses or anything, have those taken care of before starting treatment, because those tend to be vulnerable areas that will flare up during treatment. So I think if you counsel your patients on the toxicities to expect, you start at a bit lower dose, be very proactive at trying to prevent toxicity as much as you can, and then seeing how they tolerate that first cycle at 120 milligrams. I don't have a lot of patients that tolerate the 160 milligrams, and so unless the 120 milligram dose was just a breeze, I'm not escalating to the 160 milligram dose with the second cycle, but you certainly can. I do have colleagues where their patients aren't tolerating the 120 milligram dose and will back down to the 80 milligram dose and still have stable disease for some time on that dose as well.
Very good. Well, let's bring this session to an end, and then we'll come back and we'll have more roundtable discussion. So thank you all for watching this session of the Doc Talk, focusing on clinical utility of angiogenesis inhibitors in metastatic colorectal cancer.